Clear light, please.
Okay. So good evening, all AIS members, and my regards to all the presenters as well as chairpersons and all the people who are present as a panelist today. Well, friends, this is the monthly webinar which ARC has been doing since last 3 years on a third Friday of the month. In this particular month, we are going to have a topic that has been selected by our own member South, ARC member South, Somshila Murthy, that is demystifying allergic eye diseases. Lot of changes has come in the way we look at the allergic eye diseases. Lot of new pharmacological options are now available to you. So how best we can make use of it, how to have our diagnosis. Well, let us hear from all the stalwarts in this field. So without much ado, may I request Dr. Somshila Murthy and Dr. Kasturi Bhattacharya ji, who will be the moderators for today's webinar. And before that, I would once more thank Somshila Murthy, who has single-handedly designed and is about to execute the whole webinar. Thank you, Somshila. Over to you.
Thank you very much, Prashant. It's really my honor and privilege to be conducting this first webinar for me, at least, on this platform of the Academic and Research Committee. And let's dive straight away into our webinar. We are very fortunate that we have two extremely talented and senior cornea specialists, Dr. Nikhil Gokhale and Dr. Anil Radhakrishnan, who will be chairs of today's session. And we have a host of speakers who will also double up as panelists. And my colleagues from the members of ARC, including Dr. Kasturi, will be participating in today's meeting. So the way we have set it up is to have a few talks which will give us information and probably stimulate us to start asking questions to the panelists. And I'm not sure if we'll be getting questions on the chat box, but if we can have some way of getting hands on the questions, then we can ask those also from the audience live in the webinar itself. So Dr. Prafulla has also joined us. So he too will be serving as one of the panelists. Let's go into the format. We have 6 talks, but we can interrupt these talks, ask questions. The panelists can ask questions in between. And after 3 talks, we'll take up Saransh, which is what the chef, Dr. Prajakta Dandekar, is preparing for us today, in which he has prepared a nice dish, which includes all the latest updates on what has been published on the subject of allergy, which is relevant to the general ophthalmologist. So let's go to our first speaker, and we are bringing to you Dr. Shweta Agarwal. All of you know that Dr. Agarwal is a senior cornea specialist from Shankar Nethralaya. And she is taking us through the very basics, classification and grading in vernal keratoconjunctivitis. As you know, that VKC is one of the major forms of allergic conjunctivitis. And she's also going to take us through tips on how to apply this in our practice. Over to you, Shweta.
Thank you so much, Dr. Somshila. And again, a big congratulations for really putting up this beautiful program together. Can I share my slides?
Please do.
Are they visible?
Yeah.
Yeah. So without any further delay, let me start. So I'm Shweta from Shankar Nethralaya, and I'll be taking you through the classification and grading of vernal keratoconjunctivitis and a few cases to understand how we can clinically apply them. Well, we all know that vernal keratoconjunctivitis is a bilateral recurrent ocular allergy, which is predominantly seen in the male child with a childhood onset. They are often seasonal, but in countries like India, we often have the perennial variant. Diagnosis is primarily clinical, and we look at the types. You have the limbal, where you see the limbal papillae and the HT dots, or you have tarsal, where you have tarsal papillae. Often in our population, what we see more commonly is the mixed, where you have both limbal and tarsal presentation. Now, the active disease is when the patient is complaining actively of itching, watering, redness, sometimes even of blurred vision. Signs, clinically, you will see the patient having a conjunctival hyperemia or congestion. There is a papillary reaction at the limbus called as a limbal papillae, or they could have large tarsal papillae. Patients might have ropey discharge or Horner-Trantas dots, which are whitish deposits around the limbus. So you will see a whitish grayish ring kind of lesion around the limbus. In sometimes, these children can also present with what we call as a shield ulcer, which is a sterile ulcer with an inflammatory fibrin layer over the base of the ulcer. Now, in the quiet disease, since we are a pigmented population, we often see a brownish discoloration of the eye, which occurs because of the dispersion of the pigment resulted from chronic itching. The patients often have a history of itching, and they might complain also of diminution of vision. Signs clinically, you will see a conjunctival pigmentation or pseudogerontoxon, something like an arcus, but in a younger patient. Now, what are the corneal telltale signs? Often we see patients who present to us with a corneal scar, which would be indicating an old shield, resolved shield ulcer, which may or may not involve the visual axis. Complications, a chronic VKC can result in limbal stem cell deficiency, corneal ectasia that we call as keratoconus, and an inadvertent steroid use can result in steroid-induced complications like glaucoma and cataract. Now, when we say persistent symptoms, what we actually mean is that the frequency of these episodes of activity is more than 4 episodes per year. And we define chronic persistent symptoms as less than 1 month of symptom-free period. Now, also, sometimes you will see children who have severe atopic dermatitis on the face, which involves the peripalpar area or the oral area, and have features in the eye similar to that of vernal keratoconjunctivitis. Now, there is still not a consensus on whether you will call as atopic keratoconjunctivitis or you want to call it vernal keratoconjunctivitis with atopic dermatitis, where it's just a difference of the terms, but the treatment remains the same. Now, we went through 1,000 plus cases that we have been seeing at Shankar Nethralaya for almost more than a decade. And we came up with this universal grading for managing and classifying patients with vernal keratoconjunctivitis. The need for this was the current classifications that are available talk about grading and classification only when they present to you in the active stage of the disease. But we all know that subclinically, the disease still continues. Even if the stage is quiet, the child will have complaints of itching, and we need to control that. So that is why we came up with this universal grading, which takes into account not just the active stage of the disease, but also the quiet. So the grade 1 or mild is mild seasonal symptoms where you have only during the seasons. They may or may not have active signs. Moderate is now the symptoms are becoming more persistent. So they are more than 4 times in a year. They may or may not have active signs that we spoke about, the limbal papillae, congestion, Horner-Trantas dot, but still there is no corneal involvement. The minute they become severe, the corneal involvement starts and the symptoms become more chronic and persistent. So you have less than 1 month of symptom-free period. So the entire year, the child has a red eye or itching and redness, or even the child could present to you where he's asymptomatic, but has corneal telltale signs where there is a scar which tells you that it's an old resolved shield ulcer. In very severe cases, the symptoms are chronic and persistent. They have corneal involvement with the corneal telltale signs, or they could be asymptomatic with complications that we spoke about, like keratoconus, limbal stem cell deficiency, or steroid responders. Now, how do we manage them? So we have also recommended treatment guidelines. In the milder versions, you can just use the seasonal dual-acting anti-allergics. Moderate, start using on and off low-dose steroids during the period of activity. And this is where the referral to the allergist becomes important, because now your symptom is becoming more moderate. So if there is a systemic component which needs to be taken care of and is contributing to the ocular allergy, needs to be addressed, and therefore referral to the allergy specialist. Once it becomes severe, in addition to whatever we were using, here is where the topical immunomodulators, that is your topical tacrolimus or the cyclosporin, come into picture. In addition to managing surgically whatever requires an intervention, like your cryotherapy or excision, mucous membrane graft for giant papillae, or an AMT for your shield ulcer. The very severe ones, all of the above, along with some pulse dose of high frequency steroids or short course of oral steroids. In addition, as I said, from the time it becomes moderate, referral to the allergy specialist is recommended. Now, the broad treatment guidelines is it's important to explain the nature of disease. We need to counsel the parents that it is a condition which is not acute. It is not something which is going to settle down in a week or 10 days. The child is going to have it. They need to avoid the allergen as much as possible. Avoid exposure to environmental triggers like sunlight, dust, mud, cold compresses whenever there are activities or severe itching, and tear substitutes to flush out the allergens. Now, let us go through a few cases. So the milder ones, like we said, they are mostly seasonal, a little bit of irritation, itching, on and off redness. They do very well with dual-acting medications, like your mast cell stabilizers and the antihistaminics combined together. In the moderate cases where the symptoms become a little more persistent, but there is no corneal involvement, along with the dual acting, you can give them on and off topical steroids, low dose ones, and refer them to the allergy specialist. Now, these are the different groups of medications that are available. Now, of this, the NSAIDs are completely out, and the vasoconstrictors, that's not something that we recommend or advocate at all. Now, the next or the most often used is your dual-acting agents, that is L-caftitine, azilastine, bepotastine, or Olopat, which are all available in different concentrations. We really do not have any literature to tell us that this is better than the other. So, you can try one or the other. Steroids, again, only primarily during periods of activity. And usually the soft steroids like your loteprednolol or fluoromethanol do well. You very rarely need the stronger ones. But it's important to taper and stop the steroids. Now, as I said, we really do not have a study to tell us whether which of these is better than the other. They all have dual action, act on both antihistaminic histamine receptors and mast cells, and they also have some anti-inflammatory component. They can cause some amount of burning and dizziness. Bepotastine does sometimes cause some amount of taste impairment also, but then it's not in all patients. Varied concentrations are available. It's always better to start with the lowest and then step up if you feel that the patient is not responding to it, and also increase the frequency if required. Now, how long can the patient be on dual anti-allergics? Well, these are not medications that we really are worried about or have major side effects other than a little bit of toxicity from the preservatives. But I do have children who've been on dual acting anti-allergics for more than a decade, and they're all doing fine. Now, topical steroids, like I said, primarily indicated during the active disease, only when you have persistent severe symptoms. And only recommendation is short duration pulse therapy with soft steroids. Very rarely you will require the high potency one when the soft steroids are ineffective. Now, in these severe cases, in addition to whatever we have been using in the mild and moderate ones, the topical immunomodulators come into picture, because here you have a moderate to persistent symptoms and you have starting to have a corneal involvement. So you're not able to get the patient off the topical steroids. So start the topical immunomodulator and yes, refer them to the allergy specialist. Now, as was done for him, he was diagnosed as allergic rhinitis and his skin prick test was negative. The allergist initiated a nasal spray on topical immunomodulator and his rhinitis treatment. The child is now very well, the disease is very well under control, and the child is comfortable. Now, when we talk about topical immunomodulators, we have tacrolimus and cyclosporin. Well, anything less than 2% cyclosporin has almost a placebo effect in the VKC that we see in our group of patients. Tacrolimus 0.1 and 0.03 are good enough, and they do better than the cyclosporin. Even tolerating tacrolimus is easier. They are indicated in severe and recurrent cases and primarily as a steroid-sparing agent.
Rita, can you wind up? Because it's finished.
Yes. Yes. And now, how long can the patient be on topical immunomodulator? Well, they can be on almost for a decade, because again, we've had patients been using it for a very long time without any specific side effect to it. This is another patient where it was a refractory mixed VKC, diagnosed as rhinitis, treated for his rhinitis and skin prick test showing allergy to dust mite, started an immunotherapy, showing significant improvement in symptoms. We also have a concept of adult onset VKC where the signs and symptoms are similar, but here you have patients presenting beyond 18 years of age where the treatment and presentation is similar. So to sum up, we have a variable presentation. You do have a condition called as adult onset VKC-like disease. These patients of VKC often have the chronic, recurrent, and refractory version, and disease and treatment-related complications could be side-threatening. So the treatment recommendation is one, when the minute it becomes moderate to severe, try and refer them to the allergist in addition to following the treatment algorithm. Thank you so much.
Thank you, Shweta, for this excellent and comprehensive presentation where you classified VKC for us and you talked about its major clinical manifestations, as well as you went through in fairly good detail about the management. So I thought we have people from all over India, as I said. So VKC is kind of endemic in all over India. And in fact, it's more in the rural population as compared to urban population if you go to any state or any place. So, what is the variation? Maybe anybody can take up this question. So, in North India, you see them from North India, you usually see the mixed form, whereas from South India, probably the limbal. So, say, Anil, where you practice, what is the predominant form that you see?
I think it is the palpebral form only, predominantly.
Yeah,
Uh,
that's what's
but
been
but
reported because
yeah, yeah. But I think do come across patients who have a combined picture also.
Pragya, at LVPI, we see a lot of patients coming in from North India. Ikeda is also here. So, what are the predominant variants that you see of VKC?
I think overall, palpebral must be much more common, but I think the ones that catch our eye and the ones who end up into mostly tertiary care centers are the ones that will be limbal and mixed. So we end up kind of seeing more of them, and most probably the others are getting taken care of elsewhere. But even in the study that we did in children, palpebral was the most common form. It's just that I think our tertiary centers reflect a different data.
So, when
I
you
think,
do
yeah, even I agree with that. I think palpebral is more common, but lots of times the patients that we get would either have mixed form or we might see limbal more commonly rather than the palpebral form because they come after getting treated at multiple places. So that's probably the difference.
And Nikhil, in your practice, and next is Jayesh, because Jayesh is in Gujarat, you're in Maharashtra, but in Mumbai, in a metropolitan city. So, what is the predominant form that you see?
Yeah, I think we see all forms actually. The only thing, as everyone has mentioned, the severe corneal disease is what patients come to us with. So most often it is either limbal involvement or sometimes giant cobblestones causing corneal pathology, and then they land up to a cornea referral place. But in general OPD, we would of course see more of the palpebral mild varieties, which are often not seen in a referral clinic, but in our general practice, we see a lot of palpebral varieties, but the corneal problems are the ones who land up into a referral center.
Jayesh, how about you?
Yes, again, there would be a referral bias because most of my cases are those seen by other doctors and then they come to me. So most of the cases I see are a mixed form. And I really don't, I mean, after all these years, I don't really know whether it makes sense to differentiate between a palpebral or a limbal or a mixed VKC because a child with allergy is a child with allergy and needs treatment.
Shiva, you're smiling, but you have any difference of opinion? Because I think you see a cohort of patients, not necessarily with very severe disease. You're muted, Shiva.
So basically, most of the time, if at all you're practicing cornea, you see all referral cases. But most of the general ophthalmologist is more or less easy for them to treat mild and moderate cases of VKC. The only referred cases are always some complicated cases or some glaucoma cases post steroid usage. So either whoever is practicing cornea or in institutes, we see a mixed and a limbal. But most of the time, it is only the palpebral form that is treated by general ophthalmologists.
So we seem to have a slant towards all specialists here. We have all specialists here, but where we are practicing, Supriya, myself, Prajakta, so we get patients directly from the community over there. So we are the first level doctors who they're showing to. So I would say pretty much almost 70 to 80% patients have mild disease. And it's only the 10 to 20% that luckily, that have severe disease. So, but the only problem is, of course, it keeps coming back and, counseling and so on. So we have to find something, if we can solve the problem faster for them, for the children, that's good. But most of the time they keep coming back. So counseling is what is required.
Yes.
So we segue very nicely into the next talk. So as Shweta talked about what we are supposed to see for VKC or for allergic conjunctivitis. Ikeda is going to take us sort of exact opposite, and she's going to talk about the mimickers of ocular allergy. And she has a wonderful presentation of various mimickers. Over to you, Ikeda. Dr. Ikeda Lal is in private practice in Delhi and also at Sri Gangaram Eye Hospital.
Thank you so much, ma'am, for including me in this webinar, and I will talk about the various mimickers that we see. So the topic was ocular allergy and its mimickers. So ocular allergy is basically often overdiagnosed because there are a lot of conditions that can mimic ocular allergy because they all present with these common symptoms of congestion, chemosis, watering. But the predominant symptom we have to remember of ocular allergy is itching, and this is what we need to ask for. Itching leads to eye rubbing. So we can ask for eye rubbing as well as itching. Now there is a gamut of types of allergic eye disease, starting from the mild ones like the seasonal allergic conjunctivitis or the perennial allergic conjunctivitis. Dr. Shweta talked in detail about VKC, and then we have AKC or atopic keratoconjunctivitis, and we might see GPC as well. So these are the types of allergic eye disease we have, and we have differentials for these. Before I begin, just to summarize the clinical features, VKC has already been discussed. So we have more of upper tarsal conjunctival involvement as well as superior limbal involvement. And when we are looking at mimickers, we need to look at what mimics the upper tarsal conjunctiva. And then we have sometimes patients with AKC which might have inferior tarsal, lower tarsal involvement. And staining the ocular surface is a good tool in the OPD to always see and assess the activity, how severe the disease is. That really helps us in assessing whether we are looking at a disease which is fairly active. So with this, we come to the topic mimickers of ocular allergy. We have the conjunctivitis group of disorders. Then we broadly have the dry eye group of disorders and a few other conditions like episcleritis or even MMP, which can be a differential diagnosis for some complicated cases of AKC. So let's begin with viral conjunctivitis. This is most commonly what we see in a general OPD. The confusion is between whether this is a viral conjunctivitis or whether this is an allergic conjunctivitis. So here in viral conjunctivitis, usually the patient's predominant symptom is more of irritation, foreign body sensation rather than itching. They might have discharge, so they might complain of stickiness of lids in the morning. This is one question we can always ask. If their lids are sticky in the morning, then and if they have associated lid edema along with stickiness, it is more likely to be a viral conjunctivitis, and it usually involves one eye and spreads to the other, although allergic conjunctivitis can also be completely a lot asymmetric in presentation. Then we see some discharge in lower fornix, which might not be as purulent. It might be more serous in viral conjunctivitis. There is more of a follicular reaction than the typical papillae that we see in cases of ocular allergy. And then later on, after some time, we can even see these membranes and pseudomembranes that might form after a couple of days in conjunctivitis, or they can present with this. And these patients might also subsequently develop corneal involvement in terms of subepithelial infiltrates more than SPKs that we can find in allergic eye disease. Then we also have associated viral URTI that we can ask for. So these are a few of the pointers that we can help in differentiating us from ocular allergy. Now, toxic conjunctivitis is something that we need to keep in mind. Here, the congestion is more in the lower tarsal conjunctiva rather than the upper tarsal conjunctiva, unlike ocular allergic eye disease. And we have all the signs and symptoms in the inferior part of the cornea. We might have some corneal edema as well or inferior SPKs, and we need to ask for some history of using any drugs or drops that the patient has been using. Or there might be some history of exposure to some plant extract. Lots of times patients are on multiple medications or anti-glaucoma medications and might develop this kind of a toxic conjunctivitis sort of a picture. In kids, especially because a lot of kids present to us with VKC, we need to also differentiate flick-Tendler keratoconjunctivitis from VKC. Here, typically it is unilateral, and when we stain this, we'll see one nodule, and on fluorescent staining, this will probably take up stain, and this can progress to a flick-Ten like this, which has a corneal flick-Ten involvement as well. But it is usually unilateral, unlikely to be bilateral, and we might not see significantly papillary reaction. So staining is again important. That helps us differentiate between the two. Now we have the very commonly misdiagnosed mebomitis and blepharitis group of disorders, which are most commonly what we see in our OPD and misdiagnose them as allergic conjunctivitis. So these patients, again, first symptomatically, they present more with irritation or sort of a burning and watering rather than itching. And we need to take a closer look at their eyelashes as well as their meibomian glands. And really, before we go to the cornea or even to the conjunctiva, we need to ask them to close their eyes, look at their eyelashes properly. And that's how we can pick up, just to remember looking at the lids. Now, sometimes they can present with this marginal keratitis, which can be a little confusing because it can look like limbal papillae. Now, typically it has been described that marginal keratitis will have a lucid interval, but this is not always the case, as we can see for this patient. Here, the infiltrates that we typically see will be at the area where the lid margin touches the cornea. So this is something that will help us in differentiating between the two. SPKs again can be more inferior in cases of meibomitis and blepharitis, and helps us to examine the meibomian glands in infrared light as well. Now, another important thing to look for is patients who have demodex and pediculosis. So this is actually a 4-year-old child who was being treated for ocular allergy for a long time because he had symptoms of irritation and itching. But actually, when we examined him, what we found was this crusting that we can typically see on the lid margin. So this is very peculiar. This is not what we will see in any form of allergic eye disease. And this child actually had pediculosis, as we can see here. And he also had pediculosis in his eyebrows as well. So we need to treat pediculosis, need to keep demodex, which is a common pathogen, in mind. And this can really look like allergic eye disease. In kids also, before I go to aqueous deficiency dry eye, undiagnosed refractive errors can cause eye rubbing, and that is also something we need to look at. Then we have this aqueous deficiency dry eye kind of group of disorders, or we can have a mixed dry eye, which again presents in older age group with sort of pricking, burning sensation. Sometimes we do get patients who complain of inner canthal itching, and that can actually be dry eye rather than ocular allergy. So this is something that we need to keep in mind. Then we have a few of these atypical presentations of SLK we can sometimes find, where it is associated with thyroid abnormalities. And this can be confused because, again, it has upper tarsal conjunctival involvement, but we need to look at the redundancy and of superior bulbar conjunctiva. And sometimes we can find filaments which are unlikely seen in VKC or ocular allergy. So this is again a rare differential diagnosis, at least for a general ophthalmology practice, to be kept in mind. Again, a rare differential diagnosis is floppy eyelid syndrome. These patients actually usually do not complain of itching per se. These are male obese patients with very lax tarsus, which easily gets averted. So these patients can present with papillary conjunctivitis, SPK signs and symptoms, and it can correlate with the side on which the patient sleeps. So this is something that can also be seen and misdiagnosed as ocular allergy. Then we have episcleritis. Episcleritis patients usually just have a painless congestion with very mild discomfort. They do not have any itching. There is no papillary reaction, and usually resolves with just NSAIDs and lubricants. A rare differential for AKC can be mucous membrane pemphigoid, because AKC can subsequently cause corneal scarring, fornical foreshortening, symblepharon. So here, this presents mostly in elderly individuals. They will not have any other signs of atopic dermatitis, and they have severe dry eye with all of these signs that we just discussed. So their management is completely different. So we need to keep this rare differential also sometimes in mind when we are looking at patients who have significant conjunctival scarring and as well as corneal scarring. So just to narrow down the differential diagnosis, first of all, if we look at prominent symptom, if the prominent symptom is burning and ocular irritation more than itching, we are probably looking at the dry eye group of disorders. If the prominent symptom is discharge and stickiness of the lids, especially if it's unilateral to begin with, we are probably looking at conjunctivitis. And if the predominant symptom is itching and eye rubbing, especially if it is recurrent, we are probably looking at ocular allergy. So before we even examine, these are some of the symptoms that we can ask for. And again, to just narrow down the differential diagnosis, if the patient doesn't have ocular itching and redness, it is unlikely to be ocular allergy. We need to look at the lid margins to look for meibomitis and blepharitis. We need to ask for skin manifestations, as well as we also need to ask for other manifestations of atopic disorders. Like these children can sometimes have asthma, they can have rhinitis, which is associated. So these are the questions that we must ask when we have a patient walk into our OPD. Is the patient a contact lens user? Are we looking at GPC instead of VKC? And if the patient has a severe seasonal itching with ropey discharge, the typical appearance that we discussed with the diffuse bulbar pigmentation, we are probably looking at VKC. Again, something that typically here in Delhi, we find the AQI as soon as it rises, we get a lot of patients with sort of an irritative kind of conjunctivitis, which is related to more of an irritation with smoke or pollution. So sometimes in the tier 3 cities, we might get these patients who resolve quickly as soon as they are provided with some lubricants and maybe some other mild drops. They really do not need steroids. So these are the few things just to narrow down the diagnosis. And with this, thank you so much for including me in this webinar. And thank you. I'll hand over the mic to the next speaker.
Thank you, Ikeda. Just a couple of questions or comments from the chairs.
Yeah, so I think one important thing is that, one of the very important confusion arises because we see a lot of children with pediatric blepharoconjunctivitis who have corneal involvement, like the picture she showed with the pannus and vascularization, typically more often inferiorly. These are again bilateral, these are again chronic, and these are often confused by general ophthalmologists and treated on lines of VKC. Though you might still use steroid for them or you might use cyclosporin, whatever, but they're often confused and they're not truly VKC at all. So that is one important differential especially in children. With regards to, of course, ocular surface problems, dry eye, they are anyway not those severe varieties where we would be typically worried even if we go wrong. And even if you go a little bit with the treatment on either way, it doesn't matter. But I think this pediatric population is where, I find that they're often misdiagnosed, and because they often end up with scarring, which is irreversible with vascularization, and they need timely diagnosis and management.
Do you think some of these pediatric cases are Demodex?
Yeah, so basically that's what I'm saying, like rosacea, Demodex, lid margin disease, and sometimes maybe systemic infections which may be causing these type of flick-tenules or these problems. They need to be identified. So sometimes once you label it as VKC, you just keep treating them without looking into any of those other underlying factors, and that's where probably we miss the bus.
So what is the one symptom and one sign that everybody here looks out for, to rule in VKC? Obviously not the signs which are very, very overt. I mean, in a patient where you're not sure whether it's VKC versus something else. Anyone can take it up. You won't be charged for it or you won't be punished for it.
Can I make a comment?
Of course.
Yeah. So I think I completely agree with Dr. Nikhil. I think blepharitis is one very, very, very most commonly misdiagnosed condition as VKC. So if to answer your question, Dr. SS, I think it is itching. If there is itching, there is allergy. So I often ask the parents, if there is itching and redness and I can treat only one, which is your priority? And that decides my diagnosis. If they tell me redness comes before itching, then I know that I'm probably not dealing with allergy. But if it is itching, then it is allergy.
So in a pediatric patient, when you say itching, you mean that does the child rub the eye?
Exactly.
Or even if it's adult, you say, do you do this? Do you do this?
Correct.
Yeah.
That's what I usually ask. And sign up. So you already said itching over redness and sign.
Sign is
Not the obvious ones. So that is a no-brainer. Like you have big papillae, not that. So for me, that pigmentation.
Conjunctival pigmentation.
Pigmentation, yeah. So that diffuse pigmentation, and also children, if they are lighter complexion, then you can see the dark circles. So those for me is that the child is rubbing the eye. This is difficult in pediatric patients more than adult because the history is a little difficult. So, and how do you diagnose Pragnya? Burnt out VKC?
I think
because she's been my fellow.
So I think pigmentation is a very consistent feature of all burnt out VKCs, whether it has been something mild or something severe. And I oftentimes see patients coming back, there's no active allergy, but it's the pigmentation that they're concerned about because their eyes never become white, and you have to tell them that they're never going to be white. It's just a imprint that the allergy has left. But again, sometimes the limbal architecture is disrupted, or you can get a pseudogerontoxin kind of a picture superiorly, or there may be very faint subconjunctival fibrosis in some cases who've had a very bad palpebral variant. But otherwise, I think pigmentation and that muddy looking conjunctiva is something which is very consistent with burnt out allergies.
Anybody else wants to comment on anything? On this matter, not on anything. Yeah, so the reason why I'm asking for burnt out is because sometimes you get patients referred, as all of your cornea specialists, with that diffuse peripheral scarring. So it's a corneal scar, but actually you have to go back and see. So maybe it's a young patient. Now the patient doesn't have allergy, but then when you have the diffuse muddy pigmentation, go back and see that maybe it was chronic VKC after all. And that is now it's burnt out. So that is literally a benign diagnosis to have at this stage. And we don't need to do anything. So with that, we come
Also
to
have long eyelashes, Dr. Somshila,
Oh,
because
yeah,
it's like
okay.
a protective phenomenon which the body makes, where they often have very long, beautiful eyelashes. That's a
Okay.
self-defense mechanism by the eye.
What I've noted is that these children are usually very hyperactive. I'm not sure if others have noted the same. So the pediatric patients are quite hyperactive who have allergy. So we come,
Oftentimes, a lot of
yeah.
the
Is my connection bad or?
redness in the eye, the same mucosal involvement. So rhinoconjunctivitis kind of a picture. So there's always in many of them a history of rhinitis in and around their time where they have an allergy episode.
That's a very good point. So we'll go to the next presentation, and this is from Dr. Jayesh Vazirani, who is a very brilliant and somebody I really admire, a practitioner from Ahmedabad. And he is the best person to do this because he can convince you to this way or that way based on what his conviction is. And he's going to talk about systemic immunomodulator therapy. I know he's a strong proponent for that. So what are the indications? I'm hoping that we'll all understand much better. Over to you, Jayesh.
Thank you very much for the invite and the introduction. Is the first slide visible?
Yes, it is.
Yeah, right. So these are my financial disclosures, but they have no bearing on this talk. So why do we need to talk about systemic medication for an eye condition? The simple answer is that in ocular allergy, especially the severe forms of vernal and atopic keratoconjunctivitis, there is a subset of patients who go on to develop recalcitrant disease which is not amenable to topical therapy or even injections in or around the eye. And some of these patients again go on to develop secondary complications. So it has been mentioned by the earlier speakers that they can have limbal stem cell deficiency, they can have corneal scarring, keratoconus, and as an effect of the steroid use, they can also have, and quite often do have, cataracts and glaucoma. So there is a specific subset of patients who are not effectively treated with just eye drops or with injections, and that is why we need systemic therapy. And this is the rationale for discussing systemic immunomodulatory therapy for ocular allergy. In the same breath, I must also sound a note of caution that this is not meant for most of your patients. So someone was mentioning that 8 out of 10 patients will not have very severe disease, and I agree. So that would leave us with about 20% of patients in the severe spectrum of disease who go on to have chronic or persistent or recalcitrant form of disease, whatever you may want to call it. Again, out of these 20%, again, if you really treat them properly, patiently, and go on and follow them up, maybe not all of them will need systemic therapy. So you end up with somewhere between 5 to 10% of your total cohort of patients with allergy that may need this therapy. So please don't take the wrong message from this talk that for every patient of ocular allergy, you need systemic therapy. You do not. The second point is that for you to be able to treat patients with systemic medication, either you should be very interested in this and you should be trained in using these drugs, or you should be able to work with someone who is able to do that. So that may be an ocular surface specialist or someone like a rheumatologist or an immunologist. So when do we specifically use systemic therapy? So Dr. Gokhale has been working over the past many years with the specific aim of categorizing and classifying ocular allergy. So this is one of his earlier papers where he very nicely put allergy into two things. One is how severe it is, from mild, moderate, severe, or blinding, and whether it is active or it is inactive. So whether it is intermittent or chronic. So typically we would need systemic therapy for the more severe forms of disease, the severe and blinding forms of ocular allergy. And that by definition tends to be chronic and not intermittent. So recently he has also put together a new paper which has come out in March this year, which further refines the classification. And now we have a structured algorithm-based management strategy. Or any of you who are interested may go through this paper and you'll find a specific use case for systemic therapy. So these are the kind of patients who have very severe symptoms, very severe signs. They have chronic disease throughout the year. Almost all of them will have one or maybe even more of the complications that I discussed. The other use case is where you have not blinding disease, but moderate to severe disease. However, the patient is a steroid respondent. So you can't keep giving eye drops containing steroids, otherwise they will go blind due to glaucoma. How do we do this? So if you look at the pathogenesis of this disease in general for VKC and AKC, there are two main therapeutic targets that are available today. One is the T cell activation and the downstream consequences of the T cells, and the second is the mast cells. So as of now, we have two major approaches. One is one can use either cyclosporin or tacrolimus. So both of them will inhibit T cells. So you can use cyclosporin systemically or tacrolimus capsules, and both of them are very effective. There are these isolated case reports and case series on the use of these drugs, mostly for atopic keratoconjunctivitis, not so much for VKC. For VKC, there are some papers that have been published. This review basically said that you don't have enough evidence. But this is the case series that has the largest series of patients treated with the systemic cyclosporin. This is from the LV Prasad Eye Institute. And those of you who are interested in this topic, I highly recommend that you should read this paper. The other approach is, of course, targeting the mast cells and the IgE. So if you want to do an anti-IgE therapy, then you're left with what we now have is omalizumab injections. So again, there are quite a few case reports mainly and some short case series which describe the use of omalizumab injections in managing these patients. So most of them will tell you that if you go through them carefully is that it works, but it works for a very short time. So you have to keep repeating these injections. And the main problem with this is that it's very expensive. So that's not a very practically useful alternative for our patients. This is my personal experience at my center over the past few years. So these are the patients who have been on systemic immunomodulatory therapy for a minimum of 6 months. At least some of them have been on it for 4 to 5 years. So most of these patients had a very long duration of disease. Almost all of them are pure VKC, not AKC. And as this kind of chart shows, all of them had one or more comorbid conditions: cataract, glaucoma, keratoconus, limbal stem cell deficiency, and scarring. So earlier, I used to use systemic cyclosporin. In recent years, from maybe 2018-19 onwards, I've been using tacrolimus because you need lower dosages. It is supposed to be safer. And earlier, the reason for using cyclosporin was that tacrolimus was very expensive. But now we have generic forms of tacrolimus which are as cheap or sometimes even less expensive than cyclosporin. So mostly these days I use tacrolimus for this condition. So all of these patients where we use these drugs, we managed to achieve a completely quiet eyes in all of these patients, and over a long period. So this is over a period of months and years. Most of these patients maintain this quiescence of disease activity. So the aim of this therapy mainly is to avoid steroids, and that was what we were able to achieve. We were able to take most of these patients off topical steroids. Sometimes we needed to use loteprednol or soft steroids, And almost all of these patients were also tapered off the initial oral steroids. The interesting thing is that the comorbid conditions also can be managed very well. So if we treat the ocular allergy properly, most of the patients, the keratoconus stops progressing. Likewise, because you don't need to use steroids, the glaucoma is also arrested. If needed, you can even do glaucoma surgery. If the eye is quiet, one can do cataract surgery, one can do contact lens fitting, and that has an impact on the visual acuity. So all of these patients you'll see over a long period of time, because of these interventions, the visual acuity improves dramatically. So in terms of adverse effects, because the dosages that we use are very minimal compared to, say, the dosages that are used in renal transplants or liver transplants, we don't anticipate and we don't get any major side effects. What we do need to watch for is hypertension, transaminitis. So if you have raised liver enzymes, you may need to switch the drug. And other than that, there's really not much that can go wrong if you do this properly. So the key messages from my presentation are that ocular allergy, especially VKC, is not innocuous. As other speakers have alluded to, it can be and is chronic, severe, and even blinding in a lot of cases. So in those cases, systemic immunomodulatory therapy is safe. It is highly effective in achieving and maintaining disease quiescence. You need very low doses relatively compared to other conditions, and it is very cost effective. So a child or even an adult who just has to take a tablet once or twice a day, it is convenient, it does not affect their work or it does not affect their studies, and it's not very expensive. Again, there are practical difficulties. The major one is that as eye doctors, we are not usually trained in using systemic therapy. Apart from people like Dr. Somshila Murthy or Dr. Virender Sangwan or people who do uveitis, most of us will not use systemic drugs. So that is mainly a mental block. But those of you who are interested and are willing to train yourself, it is very rewarding. So if you train yourself, you become familiar with it, you'll be able to counsel your patients better because you yourself believe in it. And the lack of evidence is another issue, but that is because the number of patients who need this therapy are less. So you won't have very large numbers in studies. So again, this is a pitch for the meeting that we do every year at Ahmedabad on cornea and ocular surface. We have basically the who's who of cornea and ocular surface specialists across the country coming to Ahmedabad. This year it's on September 19th and 20th. It's a combined meeting, the ocular surface workshop and Ask Me Anything. So those in the audience who want to learn more about allergies, other similar conditions, please make it a point to attend this meeting. This is the QR code for registering, and for more information, you can always contact me. Thank you very much.
Thank you, Jayesh. I think you put everything together so well. And also the disclaimer was very loud and clear that this therapy is not for a majority of patients, but for the minority which have all the indication that you've listed. So Nikhil, obviously I would say that I would attribute, if not all, but quite a large share of our existing knowledge on how we manage these patients to you and your publications. So how frequently are you forced to start this therapy in your, like if you say percentage wise in your practice?
No, I think it's extremely rare for that matter. So I would say maybe one patient in a year or two patients in a year. That way, it's pretty rare because most patients, once you manage them properly, they may not need this type of treatment. Even in a referral practice, like I see particularly large volume of allergy patients, it's not that we need them very frequently. And I would also suggest that even if someone wants to use these type of drugs, it's also good to take a opinion of a second cornea specialist or a cornea specialist in your area if you're a general ophthalmologist, because sometimes you encounter patients who are started on some medication like this half-heartedly, and maybe you can manage them better even without it or with alternative agents. The other thing is not to keep using steroids and not think about an immunosuppressive medication. Just keep giving oral steroids for a long term may not be a very good option in a child as well. So just some of these points, but I must say that it's not very frequent at all. And I think we need to be trying to treat and use all other alternative options before we jump to using any of these drugs.
Anil, you had some comments on this. You're muted, Anil. Anil, you're still muted.
I'm sorry. Yeah. I'm audible now? Yeah.
Yes.
Yeah. Because I'm in a multi-specialty, I do come across quite a few patients with not just allergic conjunctivitis. They have a package of atopic dermatitis along with allergic rhinitis. So if you co-manage other things, even the ocular allergy improves significantly. Like it's markedly seen in this allergic rhinitis. If you put them on nasal spray, even the allergic conjunctivitis improves significantly. That is one thing I've seen. The other thing is this perennial allergic conjunctivitis. I do give this systemic ketotifen because the respiratory people use it very frequently and it is seen to be very, very effective. I think a lot of my PAC patients, they need only that, along with some not steroids, only the regular antihistaminics, olopatadine or alcaftidine or whatever. So we can significantly cut down the topical steroid use if you put them on. Only thing is it causes drowsiness in some people, that is true. But most people tolerate it pretty well.
Before we go to Pragnya, I think Supriya, you have some shared experience of use of oral immunosuppressants. You're muted, Supriya.
Yes, good evening, everyone. Yes, Dr. SS. So most of the not already as the other senior panelists have all have mentioned that we do not get a lot of people who require systemic immunotherapy very frequently. These are only cases who have been managed for more than a year or so with topical, and because of poor compliance or because of optimal dosing, they have not responded to therapy. So I feel oral steroids again work well, especially in school going children. Of course, the recalcitrant cases, because then they can just take it once in the morning and the dose is taken care of. But then again, it is important, as you have also highlighted many times, that it is important we do a thorough systemic evaluation in these patients before starting any kind of immunosuppression, as well as regularly repeated at interval of 6 to 12 months.
Yeah, so though Jayesh did say that some of us can manage the systemic immunotherapy, but not given a choice, I wouldn't. It's only when you can't really, the patient doesn't have anyone else to go to, then I do. But otherwise, my first choice is always to collaborate with a rheumatologist or an allergy specialist and put that part of the management with them. And luckily, we have a lot of specialists who are willing to collaborate with us and who understand that it's for the ocular form only. Patient doesn't have anything systemic. But in certain cases, I think it's absolutely needed because certain cases it's really not only vision threatening, it's lifestyle threatening. Child cannot go to school, can't do anything. So it's certain cases I feel it's quite justified, and especially the immunomodulators, and certainly not oral steroids for any long term.
I have a very quick comment to make.
Yes, Shiva.
So I had one patient wherein he needed oral immunomodulators. I wanted to start, but unfortunately, the doctor who referred that patient to me, he never understood that cyclosporin and tacrolimus can be given orally also. So the awareness among general ophthalmologists regarding this is also very much less. So that becomes a problem. Later on, patient landed with a LVP, and we had a single star in our hospital review. So this part is a little difficult. So if at all we have a patient wherein who requires some kind of this kind of a treatment, it is always better to rope in some kind of a rheumatologist or some physician and do the treatment. Otherwise, it will be very difficult if we treat by ourselves. That's my take.
That's a great point. It's a question of understanding that severe forms need certain therapy. And if the patient had any other, like say you have uveitis, and everybody knows that you use these drugs. So for such severe ocular allergy, which is actually immune mediated now, it's a delayed hypersensitivity. So that also needs immune mediation, immune modulation. So that is the logic, and that is why we use it, and it works very well in these kind of patients when nothing else is working. And Jayesh, I've also switched to tacrolimus now, seeing that it's so much cheaper and for the reasons that you mentioned. So maybe slowly we'll see more and more patients using this drug because cyclosporin is expensive and is renal toxic ultimately. So Pragnya was very much eager to go on to her presentation. Thanks, Pragnya. The next speaker today is Dr. Pragnya Rao. She is the head of cornea and anterior segment in Kalamanji Reddy campus in Hyderabad. And it's my pleasure to witness her journey from being my fellow now to be the head. And future is very bright for her. So Pragnya is going to take us through some simple to very severe cases. All yours, Pragnya.
Thanks a lot, Dr. Esser, and thanks a lot for choosing this important topic, which is extremely relevant for general ophthalmologists. As the title goes, I'll be talking about VKC mostly from basic to complex cases. I hope my slides are visible, and I do not have any financial disclosures. So allergy, as we've discussed so far, it's very common. It affects about 10 to 20% of the population globally. Mostly in childhood, again, there's a male predilection, and then it tends to get better after puberty. And that's the general consensus or understanding. It was similar in our big data study where we looked at around 2.5 lakh patients, new patients presenting to us over a decade. And we found that about 26,000, this is again children less than and adolescents less than 21 years. And there was about 26,000 and odd patients amounting to 10% of prevalence, again common in boys. And it's a huge spectrum. Like we get the mild cases like mostly, kind of burnt out or very minimal allergy with the perilimbal pigmentation, mild papillae, or the ones which are more severe in terms of like limbal papillae, or the mixed variant where you have both the palpebral involvement and the limbus involvement. And these are more severe forms and more difficult to treat. So firstly, coming to the more basic ones, that's the milder forms. These are the garden variety of VKC that we generally see, and they have itching. The eyes go red. There's some papillae, comes and goes with treatment, but the parents generally are very frustrated that they keep going to different doctors, but the problem never goes away. So the first thing I tell them that this is going to happen till they grow a little older, till their body or the immunity takes over. But till then, they need to be patient, and it doesn't matter if they switch doctors, it's still going to keep coming back. So all we need to do is control the acute phase. Like discussed, generally, we give some anti-allergics, a little bit of maintenance if it's severe or the attacks are too frequent. We can have topical tacrolimus going in, and if they identify specific allergens, we ask them to avoid them, and most importantly, ask them not to rub their eyes. That's the story of this 13-year-old child. And again, in the same study that I mentioned to you previously, we found a very interesting trend over temporal appearance of these cases. And as you can see, majority of the patients who presented to us with allergy were again from in the first half of the year, mostly the cases rising towards the end of December up until the end of monsoon. So that's when that's how the name vernal catarrh also goes, because it's mostly seen in spring and summer months. So similarly, again, when you see the prevalence as well, we had a similar trend. So this gives us an idea of which months do we really want to keep them under prophylaxis, make sure the parents are aware now the time is coming and they need to gear up and try and avoid a more severe attack. Now, when we move on to slightly more severe cases, like the ones which have limbal involvement, this is very important because it is just like a summation process or compound interest. Every time they have an attack of the limbus being involved, there's more and more limbal cells that get damaged. And over a period of time, the allergy is gone, the child is fine, but you're bearing the brunt of how much of damage it has already caused to the limbus. And then these patients have limbal allergy. So if I see anybody who has limbal variant, now I'm much more aggressive in those children, because I know that these children are going to face sequelae much worse than the ones who just have a palpebral variant. Same goes with the ones who have really giant papillae. And probably I'm more biased because I do more of ocular surface practice, but I'm like really worried when I see a very bad limbal variant. And that's the story of this 10-year-old boy who had also history of allergic rhinitis and frequent attacks. And there's response, but then it again relapses once they cut down. And here we need slightly more severe management, like probably we give steroids in the initial phase, but I give my, every time I prescribe steroids to these patients, I tell them that this is not for use as and when needed, because most often you see the parents know, and they know that this is, of all the 5 or 4 or 3 drugs that we've given, this is the one that's the magic drug. And then they keep using it, and sometimes they end up with steroid induced complications. So I tell them, this one drug, please don't use it at your will. You can use the others. If you think you need this, you need to see a doctor. And also keep them on a slightly stronger maintenance. Make sure you have long-term maintenance with topical tacrolimus, or if they don't tolerate it, cyclosporin. And it's easier to give ointments to these children, because then they can put it in the night and sleep. And because instilling drops too many times is also difficult. And then you'll see that the recurrences frequency may go down if you've done all this and you maintained good control. But it's also very important, like we've discussed before, there's oftentimes more of systemic allergy also. Like these patients can have rhinitis, dermatitis, asthma, food allergy. So it's very important to ask for concurrent history of other systemic allergies. And this is our unpublished data from adults. So we've seen that there was significant amounts of systemic allergies noted in patients. And when it comes to asthma or chronic allergic bronchitis, very important. Every attack actually reduces the lumen of the bronchus or the airway. And then these patients will end up developing obstructive pulmonary disease. So it's very important to then treat these patients more aggressively. And I'll be talking about one such case next, which is the difficult ones. And like you can see, the kid, this child had allergies since, I think, 6 years of age. And the first time I saw him, he was, I think, 13 years. And as you can see, the child had really thickened lids, and there's some lashtosis. And you can see that there is significant inflammation in the eye, and the cornea doesn't look clear. He had a history of shield ulcer in the past, for which again got secondarily infected. And you can see that the patient has really giant papillae and a very not so good looking cornea. So you see that the epithelium doesn't look good. The cornea doesn't have its sheen. And this child actually had allergy that started at 6 years of age. And his grandparents on the maternal side stay in Hyderabad, but they stay in Pondicherry. And it's a very classic history that the mom gives. Every time he's in Hyderabad for the vacation, he's fine. But the minute he goes to Pondicherry, again, he's bad. And another important history, when I had asked, she would say that the kid would start gasping if he had just run across the street. And it's very important to ask for these things, because these children may actually be having chronic bronchitis. The kids don't know how to talk about this to parents. And then it goes undiagnosed for a very long time till it is too late. So when we ran their allergy workup, and you can see the starkly high or skyrocketing IgE levels, and this child had around 17,740, and we repeated this again at the end of the year. Again, it was around 15,000-ish, and very high IgE levels you need to rule out. While it may be common in systemic atopy, there is hyper IgE syndrome, or HIES, which needs to be ruled out, which is like a primary immunodeficiency. So it's important to refer all these severe cases to an allergologist so that they get a very comprehensive management. Again, here, need more protein steroids. We need to keep them on stronger maintenance dose. And like Dr. Jayesh mentioned, these are the categories which really need systemic immunomodulation. And we're not just talking about the eyes, but overall, a lot of organ systems in the body would be involved. And it's good to initiate this early and keep it going till the natural course of allergy has died down, and then you're good to probably take them off of medications. And these are the cases that need multidisciplinary management. So this child was on oral cyclosporin, and co-managed with another allergologist as well, because he had, and pulmonologist, because he had allergic bronchitis. And over a period of time, his cornea is much better, vision is maintained. Limbus has never been really good, but the sheen, as you can see, is much better. He's just on tacrolimus and cyclosporin, tacrolimus and some occasional topical anti-allergics, but takes his cyclosporin orally, and he's systemically well and started growing taller and his milestones were getting achieved much better. So there's a lot more to systemic immunomodulation than just controlling allergy in the eye. And while we've discussed all children, now the interesting fact is the emerging evidence on allergy in adults. So the Italian group who also again seem to see a lot of VKC especially, again reported this for the first time in 49 patients in 600 consecutive patients with allergy. And we have similar data that is in submission right now, where we saw while our children had allergy of about 10% prevalence, the frequency that we saw in adults was just 1.1%. And this was majority of people who have developed allergy in adults, in contrast to our understanding that is mostly a disease in children. And this can be due to a lot of factors, a change in environmental factors, etc. But about 11% of the ones that we saw in adults were actually spillover from their childhood onset. And these were the more severe cases who had more complications. So if we see that the allergy is not dying down close to puberty, again, another red flag, and we need to try and treat these patients more vigorously. And just to give a kind of insight, the adult allergy, again, majority were again, while majority are males in the children, we saw that there was a switch to female preponderance in adult allergy beyond the third to fourth decade, which is similar to what you see in autoimmunity. And this is generally related to the sex hormones. But just to know interesting trends, but the type of allergy was again VKC, and complications were much lesser in the adult group, but the childhood onset had more severe allergy. While we saw a lot of other complications, again, an interesting complication is the pseudoepitheliomatous hyperplasia. The reason I've put this is because sometimes it's very overdiagnosed as OSSN because it just looks like OSSN. And you can see a contrasting image of these two. This is the only complication that we saw more in adults as compared to children. But you can see there's a feeder vessel. It gives you a gelatinous appearance just like an OSSN. But here, handheld OCT can be extremely anterior segment OCT can be extremely helpful where you see an abrupt transition in cases with OSSN, whereas here you see an epithelium which is there, but this lesion is actually subepithelial. So just for the general ophthalmologist, whenever you see this, when you look at pigmentation, which is more dispersed across the entire cornea, it may be pseudoepitheliomatous hyperplasia, but again, it's very important to send these patients to somebody who sees a lot of ocular oncology so that we don't miss a OSSN. Now, again, when we've spoken about the entire spectrum, we also have the ones who tend to heal very well towards the end. And as we were discussing, just with some pigmentation, but some through the course suffer with complications like shield ulcer, keratoconus, and limbal stem cell deficiency. Oftentimes, medical therapy works really well. Very rarely do we resort to surgical therapies, like in this patient who had total limbal stem cell deficiency. And in the OCT, you can see here that there's a thick pannus. And sometimes these patients do really well with simple limbal epithelial transplantation, and over a period of time, the patient maintained really good visual acuity. So
Can you come?
that's just to conclude. Yes, I've come to the conclusion. So we need to counsel about natural course, and we need to look at the age of onset and prognosticate and start prophylaxis at the ideal time. Treat children who have severe diseases much more aggressively, and then try to keep the disease under control till the disease settles down naturally. Thank you so much.
Thank you, Pragnya, for a real excellent collection of cases and insights into the disease. Any thoughts from Anil, Dr. Nikhil, anybody? Shweta?
I think, do you do this skin prick testing for allergy sensitivity? I think it's done by an allergy specialist, obviously. I would like to know the percentage of people who had the skin prick test positivity or.
So I've sent very few patients for skin prick test, but I generally send all my severe allergy patients to the allergologist for systemic evaluation and for other parameters. Sometimes they give them desensitization therapy. But as I understand, if they're actually in an acute episode of skin allergy, where their system is active, they tend to have cross reactivity to a lot of allergens, and a lot of things show up positive on the skin prick test. So it's good to send them sometime when you have controlled the disease and they're a little quiescent, and that's when I think we clinch the actual ones they're allergic to. But I don't send them routinely.
Praful, you had
So,
something.
Sulam, yes, ma'am.
Yeah.
Dr. Pragya, that was a nice talk. And I have one point to discuss here. You gave one example of kid, right, with allergic bronchitis as well as VKC. So, what happens to the ocular features once the systemic part is taken care of? Because what we get a lot of such cases at the RP center, being it's a multi-specialty, so we get a lot of referral. So even if their pulmonary part, this hyperactive airway, that is being taken care of by topical steroids, inhalation steroids, but somehow no, the the ocular features, they usually persist. So what is your experience of giving oral cyclosporin to such kids who have atopy features that includes your hyperactive airways?
So, if they've had very bad limbal damage, like the one seen in the child, we've not essentially seen complete recovery, but we've definitely seen a reduction of the density of the scarring. And even on just oral immunosuppression, I think the cornea start doing much better, and the sheen and those kind of things come back. The vascularity reduces, but like I said, we bear the brunt of the sequelae, and the initial damage, if it's done to the limbus, I don't think it is reversed completely. But again, stepping in early is again very important here so that we don't land up in such a situation. But we did see in some patients that we start oral immunosuppression, their ocular surface features, though not completely reversed, definitely improve quite significantly.
For how long you continue on an average for such kids? Oral immunosuppression?
Majority of them, close to puberty or after puberty, the disease generally goes down. So we start stepping down once they're not having too many recurrences or have remained disease free for a significant amount of time. So that's the duration where I generally prefer the child to not have recurrences for a while, and then we start slowly reducing the amount of immunosuppression.
And what would be your protocol for topical cyclosporin of kids?
I don't use, I like tacrolimus so that I give them
Yes, most
at
of us
night. They
now
put
we
it
use,
as an
yeah.
ointment and it's easier. And from
And
personal
how long?
experience as well, it's so much easier to put an ointment in your child while they're asleep than putting drops through the day. So I think the night, once in the night, works pretty good. And I always use soft steroids to control the acute
So
phase.
tacrolimus you continue for how long? Or
I
it's like,
continued for 3 months, 6 months, 1 year.
Mhm.
We've not had any issues. Dermatology literature reports maybe malignancy potential kind of
Yeah,
things, but we've not had that
yes.
experience. And we've had children on this like forever.
So
For
for
oral leukoplegia, they had that alert by FDA for malignancy, I think, but not for local uses.
Not for
Just
like,
last one question. So you don't give tacrolimus BD because few studies they start with BD and then they bring it down to OD once the inflammation is significantly reduced for tacrolimus.
because I start off steroids in the acute
Okay,
phase, I
you
just give
combine
them
that
one
with OD
because I
dose.
always combine, and then I slowly take the steroids off and they continue on the same regimen.
Any advantage of 0.9% allopatadine in these kids?
I personally like the sodium chromolate much more
Okay.
than olopatadine, but I like the topical immunomodulators more.
one
Thank
problem,
you.
Praful, is when you ask questions to different speakers here. So each of them, their experience is based on the practice and the kind of patient.
Practice, yeah, ma'am.
So what Pragna sees is what I was seeing what at LVPI, where they're very complex patients, and nothing will. So things like olopatadine or any
Yes,
of the
ma'am.
other drugs will just not work for them. About tacrolimus, just a couple of points before I ask Nikhil for his comments, is that tacrolimus eye ointment is not really an eye ointment. Sometimes you might get the skin ointment. So
Skin
this is
ointment.
play it safe, and we ask them to apply a fairly good amount. We demonstrate on the upper lid. And yours from RP Center, the study shows that there is a perfusion and it acts pretty well, even when applied as a skin preparation, because there is, it goes through the lid skin and through and it reaches the conjunctival mucosa where it needs to act. And we've been using it for years. I have pediatric patients on it for years. You can give them a disease, drug-free time if they have some seasonal variation. So if it's, that, I mean, this is for the practitioners, that if there is season during which they have allergy, then in the off season, maybe they can stop using it.
Yeah,
But
true.
in South India, I don't think we have only one season, hot, hotter, hottest. So uh, we have to use tacrolimus
Mm.
almost hardly any time when you cannot use it. So
Yeah, that's true. In fact, in winter we do not prescribe tacrolimus, but yes, but in Delhi and North India, the trouble seasons are it starts from Feb onwards.
yeah,
Until June, we really struggle with all the kids,
yeah.
and at times it's very sad also to see them suffer like this.
So I think in the data that I was talking about, it's very important for us to start the prophylaxis maybe a month
Yeah, true.
earlier
Yeah,
or couple of months before we expect, because then once they start having allergy, then starting again is less
Yeah,
useful.
there comes the role of counseling. One speaker was emphasizing on that. So parents had to be taught, please start Chromogal, glycate or whatever anti-allergy at least from Jan or maybe December.
A few
That
points
is an
for
part.
everyone, for the general practitioners, from at least from Pragna's talk, is that you can use topical tacrolimus, and I am recommending it to use on the lid skin. But if the child allows and doesn't have stinging, then you can apply it as bedtime as an ointment. And the other pearl we have from Pragna, sometimes you have these cases which are very severe. So look for hyper IgE syndrome, run the serum levels for eosinophils and IgE. And these patients, Pragna, you know that the biological has a role to play. Omalizumab has been
Yes.
proved to be very efficacious in treating systemic hyper IgE also. And obviously, if they have EKC, that will help as well.
Yeah, subcutaneous dose is quite useful.
So my question for Nikhil was, because Pragya had touched upon and Anil had asked upon the dermatological testing. So do we do it, Nikhil? What is your opinion? Where's the jury standing on that?
So basically, when you have patients who are repeatedly getting allergies, not getting controlled adequately medically, typically those parents are chronically asking you what's he allergic to. Then sometimes I give them an option of getting an allergy test.
Okay.
But of course, we need to understand that the desensitization treatment that is given can take 3 to 5 years. So the important thing here is that we shouldn't, like you send them to allergy specialist, and if it disappears from your clinic, his eye will get worse. So it has to be given parallelly.
Right.
So you need to do your own treatment, whatever it is. If it is severe case, you need to treat accordingly, and parallelly you could do allergy testing. And if they feel that they can do some desensitization, often to dust mites, which is quite common, then they can keep doing it along with the treatment. The problem again comes that there are some parents who will come with you a report where the child can't eat anything, everything is allergy is coming positive. So
Yeah,
then you
right.
don't know. But today, nowadays, you have some of these ELISA based tests which are very specific to various, the small component of the allergen is tested, and which can sort of remove these type of factors which you get allergy to every food substance, So those type of tests are pretty expensive, but could be useful.
So Shiva, in the private setup in Hyderabad, do you advise your patients to go in for allergy testing? A lot of practitioners ask me, and honestly, I don't do it. So what do you do?
So as a routine, I don't get any kind of an allergen test. As Dr. Nichols has just pointed out, if at all the parents want it, right, in the first visit itself, then I explain to them that, once you do the test, you'll have a lot of positives, and ultimately you will end up in not eating anything. So that's my main concern. So unless and until 3 or 4 visits are completed, and I'm pretty happy with the patient, and they believe me, then only I go for an allergen test. Otherwise, I generally don't advise any kind of a test. And there are lots of tests in that, the basic profiles, the extended profiles, And as Sir was pointing out, there are specific IgE tests. So all these tests, we should be very clear on what to get it done because they're very, very expensive. And I generally tell them that it costs them at least around 10 to 20,000 for them. If they're ready to do, we can go ahead.
Thank you.
Can
If
I
you do it, ma'am, if you do it in those kids
Yeah,
who have atopy,
yeah.
like they have skin, they have pulmonary disease, then these kids, it may be helpful. Although it doesn't come out that frequently positive to very specific allergens. But yes, I have, because two kids from Himachal Pradesh where the environment is quite good, still they were having allergy. And then we went ahead with this patch test, and somehow the tree that they had planted in front of their home, that was the culprit. So occasionally it's very helpful, but usually it's not that much useful. So routine testing, I think we also don't advise unless parents are specifically asking for that, or there is a clear cut history like recent change in place and there is allergy, or recent some pet has been bought and there is allergy, then we definitely, I think it will be useful in those specific cases.
Yeah.
Thank you.
Can I make a comment? Yeah.
Sure.
Yes, sir.
Well,
Yeah.
Supriya, you can just
Yeah.
start your presentation.
Uh,
Please
there
come.
is this allergy specialists talk about this atopic march. That is the progression of atopy. In the initial infancy, it may be just eczema and
Right.
maybe food allergy. Then in the teens or pre-teens, it may be just your asthma and allergic rhinitis. And in such patients, if you have such history, it's probably wise to do the test. That is one thing. Second point is the allergy specialist vouch for the skin prick test rather than the serum testing. And
Okay.
if
Yes.
you need some specific thing, you go for the serum testing, which can look at the subtypes and all that. But skin prick test is always the standard of care.
Thanks, Anil. We'll move on to Dr. Supriya's talk. We talked about a lot of medications, what to use. Now, Supriya has a brief talk on surgical therapy, especially for giant papillae. Supriya, your screen, your PowerPoint is not visible.
Okay.
Nikhil has been pinned to the main screen. Why is that? Nikhil, Supriya pinned you to the main screen. Okay. All right. So Supriya heads the cornea department at Chandila Dhangvea Institute, and she has some experience in managing patients of giant papillary conjunctivitis associated in VKC. Although the technique has been described from Shankar Netralia, Shweta, due credit to you.
am I audible?
Yes.
Yes.
But I'm not able to share the screen.
Okay.
Share button at the bottom.
Sunil, can you help out?
So while we wait, I just wanted to make a quick comment because Dr. Anil had brought up atopic march. So in the allergy literature, there's a lot of emphasis on early recognition because they believe that in the initial few years of life, the allergens actually gain access through the skin when they have eczema, and then it evolves to more life-threatening diseases like bronchitis or asthma. So that's why early diagnosis, early treatment, I think, is very, very emphasized.
Is it now visible, Dr.
Visible?
Isis?
Yes.
Yeah, we're waiting for
Yeah,
you to
Yes.
full
Make it full screen.
It is full screen.
Yeah, I think there's some delay in loading.
Is
Maybe
it now full screen?
not yet, but you can start because we can see your slide. Maybe if you knock off your video, you'll release some bandwidth for the.
Okay, 1 second.
Yeah, no, that didn't work. So you can start. Go to the next slide, then we'll see if it's moving or not.
Is it moving now?
Not for me. Yes, the slide moved, but you're still not in slideshow.
Okay.
It may be coming up. Can the support team help, please? Sunil is here.
Can we go ahead with the next one? So I'll figure out
Okay.
it by
All right.
meantime.
So
Yeah.
then we'll go on to medical therapy, and it's really my delight to invite Dr. Shiva Vuruti. He's a cornea specialist and he's in private practice in Hyderabad. And Shiva, we caught you ahead of time. So I request you to speak on the recent advances in medical therapy of ocular allergy.
Thank you, Dr. Somshila, for the wonderful introduction. So let me just share.
गर्मी में पानी नहीं पीते हैं?
Is anyone there from the technical team? Shiva, you're not able to share, or what's happening?
I'm not able to share.
Prajakta, you're up next. Are you able to share, Prajakta? Okay. So we have cook chef Prajakta serving us what is recent on literature. Just a brief intro. Saransh is a capsule on from recent literature on whatever subject we have taken up for ARC for the webinar. And what she's going to try to do is just distill what is there in the literature, summarize it, and give us some tips, some insights for the general practitioners. Over to you, Prajakta. Prajakta is my colleague at LV Prasad at Shantilal Sangma Institute. She trained from LV Prasad Institute.
Am I audible? Yeah.
Yes, Prajakta, you are.
Okay. Good evening, everyone. I'll be presenting the literature update on allergic eye disease. Okay. So why allergic conjunctivitis matters? It is because of the rising prevalence of the disease. As we see, 40% of our OPDs are filled with these patients. There is increased severity due to pollution because the particulate matter size has become less than 2.5. There is a climatic change. There is urbanization because of deforestation. There is decrease in the ozone layer. So all these things, they affect, they cause itching, they cause redness, they cause hyperemia of the conjunctiva. And this has an impact on the quality of life and productivity. Okay. So initial classification, the old classification, which we have been learning since our post-graduation days, it consists of these phenotype-based classification, which starts from the seasonal allergic conjunctivitis, which means that the allergic conjunctivitis is more in particular seasons. The perennial allergic conjunctivitis, in which it is present throughout the years, it is mostly because of the house mite or because of the dust. And vernal keratoconjunctivitis, which has specific characteristic features. Giant papillary conjunctivitis, which was initially associated because of contact lenses. It could be because of prostheses or sutures. Then there is contact blepharoconjunctivitis and atopic keratoconjunctivitis. So this ranges from mild to severe, could have individual variation. So this allergic conjunctivitis, which was based on the phenotypes, is actually classified on the basis of hypersensitivity reactions. It might be antibody mediated or cell mediated. It could be tissue driven, or it could be a direct response to the chemicals. So coming to the ocular surface hypersensitivity disease, which is now being classified as ocular allergy or ocular non-allergy. So ocular allergy includes immunoglobulin E-mediated ocular allergy, non-immunoglobulin E-mediated, and both of them, atopic keratoconjunctivitis falls in both of them. And then there is ocular non-allergic hypersensitivity, which consists of giant papillary conjunctivitis or maybe toxic conjunctivitis. So the traditional pathophysiology which we know is that when the antigen is presented to the antigen presenting cell, that is the allergen is presented to the antigen presenting cell, which is dendritic cell or macrophage, there is an activation of the B cell, which in turn activates the activates the immunoglobulin E, and there is release of the histamine from the mast cells. So this is a histamine which was traditionally responsible, and it is also now, but there are other factors which are newly associated, making allergic conjunctivitis as the ocular surface disease. So there is a multi-layer this is consist of epithelial barrier dysfunction. There could be neurogenic inflammation. There could be goblet cell dysfunction, tear film instability, and this could lead to dry eye as a component of allergic conjunctivitis. There could be persistent eosinophilic inflammation, and also there could be the ocular microbiome which is affected. So coming to the epithelial barrier dysfunction, as we see, this is a normal intact epithelium barrier which consists of zonula occludens. These are the tight junctions, and here is a defective epithelial barrier where there is a breach of tight junctions. And there are studies which done on rabbit models which also have shown that there was actually these tight junctions of zonal occludens and were loose in cases associated with seasonal allergic conjunctivitis as well as perennial allergic conjunctivitis. Clinically, they also appear when you see fluorescein staining, which is present in these kind of allergic conjunctivitis. And so this facilitates the entry of these pathogens and there is inflammation. So other neuroimmune mechanisms which are associated, which say that as the sensory nerve endings which are responsible for pain and irritation and itching, they also release substance P and
इसको कोई भी ठंडा
calcitonin
फ्रूट
gene,
देने के लिए मना किया है।
calcitonin related peptide.
खट्टा तो
So
हम
which
देते ही नहीं इसको।
hello.
लेमनेड में तो पूरा चीनी डाल के देते हैं लोग।
Yeah, so the substance P and calcitonin gene-related peptide, which is responsible for mast cell degranulation, inflammatory cell recruitment, increased vascular
आम तो हम इसलिए
permeability,
नहीं
and
देती है,
vasodilation.
दिल्ली में ना कोई भी आम प्योर नहीं है।
I think Praful is not.
नहीं नहीं, सारे मिक्स है यहाँ पे। आम के इन पे एक दिखा दो, तो सारे इंजेक्टेड वाले हैं।
किसी का ऑडियो ऑन है।
Yeah. Hello. So
Sunil?
these nerves which are so these nerve endings which are affected, there is increased nerve sprouting, and this in turn the peripheral sensitization leads to central sensitization, which the patient continuously perceives as itching. So coming to the microbiome, it has been observed, and these are the latest papers which I could find in the gut microbiota on allergic conjunctivitis, which says that when the child is exposed in the first 6 months of birth with antibiotics, then there is a change in the microbiome, and this leads to dysbiosis, ocular dysbiosis. And so, so there are changes in the microbial metabolites. There is decrease in the commensal bacteria, and there is increase in the certain bacterial species which are responsible for inflammation. So now what we see is the phenotype, and what drives the disease are these inflammatory markers. And so both of them should combine us to give a precise treatment. So as we have already discussed about increase in the tier immunoglobulin E, there are MMP9 markers, and there is impression cytology, tier osmolarity, there is eosinophilic cationic protein. All these markers could help us in prognosticating the case as well as in planning the treatment as to which patients should just receive antihistaminics or which patients need more aggressive anti-inflammatory therapy. So there are these reports in which the allergic conjunctivitis, which is associated with dry eye, that is in patients in which TBUT was also affected. These patients were received cyclosporine 0.05%, and this was in a form of nano emulsion, and it was compared with olopatadine eye drops along with lubricants. And they found that both of them, they were responsible for a good TBUT. But cyclosporine was found to be superior over olopatadine eye drops, and this study was done in 2024. So then the imaging advances in allergic eye disease, if you can see the first picture, then there is abrupt ending of the nerves here, and this is a picture of a confocal microscopy shown in cases of atopic keratoconjunctivitis. It also shows some inflammatory cells in the cornea. Then the second picture here, which shows the limbal hypertrophy in cases of VKC
Sorry,
and
Prajakta,
ASOCT.
picture show. Yeah, Prajakta, the first picture, both of them, A and B images are confocal.
Yes.
All right.
And the second picture here, which is showing the how the ASOCT was used to monitor the limbal hypertrophy, in which the patient was given tacrolimus, and you can see that after the treatment, actually the girth has decreased. Then there are other studies which were done on meibomian gland analysis in allergic conjunctivitis patients, in which they analyzed the central part of the upper lid, and they found that this was an AI-based study, and they found that also the meibomian glands, the central part of the meibomian glands, was equally affected in these patients, showing us that dry eye is a component of allergic conjunctivitis in many cases. Coming to atopic keratoconjunctivitis, which has already been discussed, it might mimic the ocular cicatricial pemphigoid, showing fibrotic changes, shortening of the phonesis, and but it is strong association with eczema and atopic dermatitis. And because of the chronic and repeated epithelial trauma, there might be partial limbal stem cell deficiency, which could be associated with atopy. So this chart has also been this is actually differential diagnosis of how allergic conjunctivitis, which has already been discussed by Dr. Lal in the previous talk. So I'll skip this. So now there are other topical formulations which differ in pH. They differ in osmolarity. If they differ in pH, they might get deposited on the cornea. They with the osmolarity, it is how the patient feels. If it is more osmolar, so it should be more osmolarity should be near about the tear film. And if it is more osmolar, then the patient finds it irritated. So even the preservatives like BAG, they are shown to affect the cornea, and the staining has shown to increase even after 7 days of usage. So it is preferred to shift to the like preservative-free eye drops. And other buffering agents and moisturizing additives also add to a good response and good like symptomatology for the patient. So the other treatment options, which are other than the normal preservative-free eye drops, they could be olopatadine, alcaftadine, which is a dual-acting antihistaminic. They could be surface protection strategies. So mostly it is about managing the ocular surface. There could be cold compressions, then the air purifiers, eye wears, and also treatment of the dry eye component. So the challenges which we find in India are the misdiagnosis as infective conjunctivitis, the over-the-counter prescription of steroid eye drops, then the pediatric VKC challenges, and the pollution-related exacerbation. So my take-home message is that allergic conjunctivitis is now viewed as an ocular surface inflammatory disorder. We should be shifting to the preservative-free eye drops. The environmental and climate factors need a major consideration. And recognizing dry eye and meibomian gland disease as the exacerbating factors should always be kept in mind, giving a personalized treatment to the patient. Thank you.
Thank you, Prajakta, for going through the recent literature and summarizing it for everyone here. Supriya, are you able to show your slides? Is it going to the? Is it going through?
I think Prajakta will have to stop sharing, Dr. SS.
Can I have Doctor?
So Prajakta can stop sharing, which is
Yeah.
Done.
So Supriya,
Yeah.
we'll just take the
Uh,
presentations first. Yeah.
Yes. Is the first slide visible now?
Yes, yes.
All right. Good evening, everyone, and sorry again for the technical glitch. So I'll be talking about management of giant papillae in VKC. Giant papillae is in VKC is mostly seen because of the tissue remodeling and the fibrovascular proliferation, typically involving the upper tarsal conjunctiva, and this is seen in almost 12 to 30% of cases of chronic VKC. Now, the size of the papillae correlates with the chronicity and the severity of VKC. And usually these patients will present to us with pseudotosis and corneal complications, which are seen in almost 7 to 50% of these patients. Coming to the corneal involvement, the papillae can cause punctate erosions, coarse epitheliopathy, corneal macroerosions, and shield ulcer formation. Shield ulcers reported in approximately 3 to 20% of cases of VKC. Now, the standard of care for managing giant papillae is, of course, medical therapy to begin with, and then adding topical immunosuppression along with the mast cell stabilizer and antihistaminics. But their limitation is the compliance because of frequent installation of eye drops, the stinging, burning sensation associated with topical tacrolimus eye ointments, and the side effect of steroids. Now, cases which do not respond to maximal medical therapy is usually where we start using surgical interventions, and this includes excision of the giant papillae in combination with conjunctival grafts, mitomycin C, a cryoablation amniotic membrane, and also subtarsal steroids is given in these cases, but the limitation here is the recurrence. Let us now look at three cases. The first one was that of 32-year-old male who presented with severe itching, redness, watering since 3 years, and he had drooping of eyelids since 1 year. The symptoms persisted despite medication, and there was a history that the patient stopped using medication as soon as he felt better. So this was the clinical picture when the patient came to us first, and we see there were presence of papillae, not very angry looking in the upper tarsal conjunctiva. This was mostly this clinical picture suggestive of a chronic disease. The right eye had epitheliomatous hyperplasia with mild limbal thickening and corneal scarring, and the left eye had few active Horner Trantas dots. So this was a mixed form of VKC. We started the patient on topical steroids and was gradually tapered. This was a clinical picture at 4 weeks where the patient was symptomatically a little better, and we continued the treatment. However, because of poor compliance, this patient had again presented at 8 weeks with worsening of symptoms. We see the giant papillae are more active now. There's more congestion. There's more amount of limbal thickening. So at this visit, we planned for a subtarsal steroid in both the eyes and the upper tarsal conjunctiva. And the patient was also started on oral cyclosporin thereafter. And this is the picture at 7 months. So here we see that the allergy, the symptomatic wise, the patient was doing well. The surface inflammation is also reduced, and the giant papillae have regressed. So the second case was a 13-year-old male who presented with severe photophobia redness since a year. Again, this patient had drooping of eyelids, and the patient had already undergone 3 times subtarsal steroid injections. And this was a clinical picture. So very they had a typical cobblestone appearance of the upper tarsal conjunctiva with discharge, ropey discharge, as we can see here. And there was presence of limbal thickening, and the right eye also had some amount of peripheral corneal scarring. So to begin with, I started the patient on topical steroid drops, and here we see that with the topical steroids, the congestion had reduced, symptoms had improved, but again the patient was bothered with the chronic, mechanical irritation with the giant papillae in the upper tarsal conjunctiva as well as with the ropey discharge. So, looking at the size of the giant papillae, excision was planned along with amniotic membrane transplantation, and post-operatively, the patient was, continued on the medical management along with a short course of oral steroids was given for almost 6 months. And at around 8 months, this patient had some recurrence of papillae in more so in the right eye, as we see here. But symptom-wise, patient was doing better. The surface inflammation was under well control, and acute exacerbations were treated with topical steroid with short courses of topical steroids. The third case was a 15-year-old male who had severe itching, photophobia, redness, drooping of lids since 2 years. And this was the clinical picture. So both the eyes had severe, severe like giant papillae in the upper tarsal conjunctiva with ropey discharge. And typically they had a lot of severe congestion here. There was no limbal component at this stage. So there was very mild surface inflammation, and the patient was already on a combination of mast cell stabilizers and topical steroids along with taclomen eye drop. He had a very interesting surgical history. The patient had undergone several subtarsal steroid injections with excision alone, along with in combination with amniotic membrane grafting. And so I thought of adding oral steroids first along with cyclosporin. Gradually, the steroids were tapered off and cyclosporin was continued. So with the systemic immunosuppression therapy, the amount of congestion reduced in both the eyes, but the size of the giant papillae remained the same. And here we can see there was presence of peripheral keratopathy because of the mechanical friction from the giant papillae, as we see here. This was at this visit, it was only the right eye that was involved, but following a 1.5 2 months, we see that the striate keratopathy in the right eye had increased, and now in the left eye also had become involved, and this was
Can
more
you be a
obvious when
little,
stained.
can you be a little concise and just go to the important?
Yes.
Yeah.
So so here the technique that was I performed the excision of the giant papillae along with labial mucosal grafting. This is the clinical picture at 2 weeks, and this is the 9 months follow-up where there is no recurrence of papillae seen, and the symptoms are well controlled as well as the surface inflammation is well controlled. So what I wanted to summarize from this slide is that different techniques following surgical excision and using conjunctival autograft, simple excision have been described, but with a very high recurrence rate, as we can see here. The oral mucosal graft alters a better alternative because the Langerhans cells, which are the ones that initiate these allergic reactions, they are non-responsive to the allergic stimuli from the labial mucosa, unlike what we see from the nasal and the skin and the conjunctival mucosa, and also some amount of mechanical debulking is performed. So this slide summarizes the management of giant papillae. So nothing needs to be done when they're inactive. We can just control the symptoms and surface inflammation with with their medical care. When they're active, but they're not inducing any type of keratopathy, again, similar topical as well as systemic therapy can be adopted for these patients. But when they are active and they are either refractive, they are causing some amount of corneal surface damage, which starts affecting vision in the form of shield ulcer, epithelial defects, corneal breakdown, corneal scarring, or the patient is troubled because of severe discharge and foreign body sensation. There's mechanical ptosis. Then we need to surgically excise these giant papillae and choose between conjunctival autograft and labial mucosal grafting. Thank you.
Thank you so much, Priya. That was a very interesting presentation. And I mean, I'm very well versed with your technique, but it's good that you could educate more people about it. What we'll do is we'll go to Shiva's presentation. Shiva is going to talk about the next generation of medical therapy. And in the end, we'll take some questions from our chairs and panelists. We'll take the answers.
Are my slides visible?
Yes, slides are visible.
Nice. So thank you. So I have hidden most of my slides while the other speakers are talking, so as to avoid duplication, so that we'll have time for more discussion. So my topic is mainly on the newer drugs that uh, have come into vogue recently, after maybe in the last few years. My slides are not moving.
Slides are not moving.
Yeah.
So maybe you can go to the.
Yeah.
Yes, it's moving.
Yes. So this slide clearly tells about the various act pharmacotherapeutics of various drugs, mainly the calcineurin inhibitors, which are long stay for the chronic allergic disease, and rest of all the mast cell stabilizers, antihistaminics, and the NSAIDs and the steroids, which are the main therapeutics that have been there since last 50 years. So we will go on with why we need newer drugs when these number of drugs are available for us, which can treat at least 90 to 95% of our patients. So mainly, the main critical unmet needs are mainly the refractive cases wherein we need to use steroids for a very long time. And second thing is about the steroid toxicity, which mainly the dependence on steroids will lead to multiple issues. Third is the limited long-term safety and efficacy evidence from for many topical agents in children, and no biologics which we are using now, they are not FDA approved. And with time, there is a lot of emerging off-label agents which are there. So in order to understand all this, so we need further newer therapies to come into the market to treat those 5% of individuals who need further good care without more side effects. So today I'll be more concentrating on only four types of therapeutics that are there. One is the biologics, the other one is LFA1 antagonists and RASP inhibitors, and the most recent one is cetirizine ophthalmic. Before I start with that, I will just include this. I have included this because I never came across this immunotherapy, which is a sublingual immunotherapy and the subcutaneous immunotherapy, both of which are beneficial to patients who are having multiple episodes. And I don't think whether we are following this in India or not, but I have never come across before wherein, weekly injections of either subcutaneous or sublingual injections are given in order to know the sensitization, and main indications being the severe systemic allergies and multiple allergic manifestations. So this actually helps us in understanding the allergic eye disease, which is there for since a long time and is chronic in nature, so that we can actually treat it in 3 to 5 years. Normal, mild, and moderate cases, this doesn't have any role. So, as far as the ocular allergics and the role of biologics are concerned, this is the anti-IgE that is commonly used, which binds to free IgE and downregulates.
I have done PRPs. I have done LASIK.
Can please mute? Others can please mute.
Yeah.
Please go ahead, Jim.
Yeah. So, though I don't have a personal experience with any of the biologics, the
Ikira, can you mute yourself, please? Please try, Shiva.
yeah. Thank Yeah, thank you. So this is the widely used biologics and ocular eye disease. So the dosing and the duration, there is no standard protocol because most of the time it is off-label use, and there is a one more one which is dupilumab, which is an anti-IL-4. This is mainly the mediators that are there in the pathway. Mainly they are used in atopic keratoconjunctivitis cases with uh, in coordination with the dermatologist. These drugs are used. There are lots of papers on this by dermatologists. So the other biologics that is there is benralizumab or mepolizumab. The ocular relevance is still not clear, but there are papers wherein one or two cases were treated with this along with skin diseases. So same thing with this also, which is anti-IL-13, tralokinumab, and lebrikizumab. These are very difficult to pronounce itself. So all these biologics are mostly cases with atopic dermatitis. So atopic uh, infections were treated. So I have run through all those drugs mainly to focus on the latest LFA1 antagonist, which is nothing but the liftigrast. There is a lot of buzz around this particular drug. I started using this since last 3 to 6 months, but I have never given this along with, all alone without using other things. I have given it as an adjuvant along with olopatadine. Then it actually works really well. It is only approved for dry eye disease, but in multiple conferences, I have heard people using it for VKC, AKC, left and right for both PK. Also, I have seen patients giving, doctors giving it for patients post PK also. It has its own side effects of irritation, burning, and altered taste sensation. Still, I'm not convinced with liftigrast as such when compared to other drugs that are there in the long term. Maybe further studies are needed on that. Then Riproxolab, I have never used this drug. This is used in neutralizing the reactive allergic species generated during oxidative stress and inflammation, which further leads to decreased cytokine release and inflammatory signaling and ocular surface inflammation. It is mainly useful in chronic ocular surface inflammation, so that the risk of steroid-related complications are less. So I have no experience with riploxanab, but there are very, very few papers on this used in few patients. Then this is the latest one that has come up, the ophthalmic cetirizine. After levetiracetam, this is the one that is making a lot of buzz because cetirizine was always thought to be very good anti-allergic orally, so antihistaminic. So this is the ophthalmic cetirizine, which is a newer dual action antihistamine with mast cell stabilizing properties. It is actually advised for mild to moderate seasonal allergic conjunctivitis and perennial allergic conjunctivitis as an alternative to olopatadine and Viport. So if olopatadine is working, I don't know why cetirizine has any other role, but it is that sometimes patients with olopatadine and Vipos also have some kind of a sensation. Maybe that this may help in that. So it is already approved with 0.24% of topical solution and is freely available in the market as of now. As per the studies, it is useful even in any patient who is more than 2 years of age. Then the future is mostly about how good we can deliver the drug onto the surface of the cornea with nanomicells or nanoparticles or nanosuspensions. And later on, the future is about the allergen vaccines and the mechanical barrier gels and probiotics. So mainly the new drugs that are there in the market right now is leftigrast and topical cetirizine. So how they perform will be known only in future, though leftigrast is very much used. So the extent in which we can use it in ocular eye disease, I mean the allergy disease, and in other eye diseases is still to be known. There is a lot of work needs to be done as far as the literature is concerned. Thank you.
Thanks, Shiva. That was really an excellent summary. And from the perspective of more of a routine, what a practitioner can gain from this. So you fit the bill, fit the brief very well. Thanks for presenting that. So we have about 10 more minutes remaining, and I'd like to invite the comments from Anil and Nikhil regarding the last two talks and their experience. Maybe first we can go reverse, talk about the new drugs, because Shiva has picked up curiosity, especially in liftigrast and its use. So Nikhil, have you had any experience, and what do you think about these newer drugs?
I normally wait for others to.
Okay. Anil?
Yeah, I also don't have experience with the Livitigras for allergy and all.
Okay. Anybody else?
But omalizumab, I can make a comment. I think in flare-ups of allergy, especially in VKC,
Yeah.
we send to the allergy specialist, and with one shot, I think it improves. 1 or 2 shots, it improves. Only thing is, it's pretty expensive.
Yeah, about this
And it's
liftigrast,
easy to take also because, like insulin, they take a subcutaneous injection, and
That,
it is helpful
so helpful for flare-ups. Okay.
for very severe flare-ups. Yeah.
No, actually, omalizumab will work only if the serum Ig levels are extremely high, and very
Yeah,
often
that
these
is true. We
children,
have to look at the serum.
yeah, and they should
And
normally they might have other forms of allergy like asthma or something which is refractory, rhinitis, multiple systemic allergies with high Ig level. Then I think it's quite good, but it has to be again repeated every 2 to 4 weeks. Again, cost factor is there, but if like if someone has asthma or something which needs, then maybe the parents are more convinced. But pure ocular allergy, again, very difficult to convince. An expensive form of treatment. There maybe, if it's really bad, you can try one of these calcineurin inhibitors orally. Otherwise, that one option is there.
While it has been looked as the drug.
Praful was saying something about
Yeah.
liftigrast.
liftigrast, what we are also using here, especially those cases which have steroid responders, and we cannot give steroid at all. And their cyclosporin is not working or it's very irritating to the eyes. So we have at least 3, 4 patients. And if VKC is active, liftigrast is not going to work. Active VKC has to be controlled with other drugs. But when in the maintenance phase, liftigrast is maybe an alternative to cyclosporin or tacrolimus. So it works well during the maintenance phase. Active phase, we tried in 2 of the steroid responders with advanced glaucoma and no option. So, but it was not that useful.
In the maintenance phase, the patients that were used, were they also on other therapy, or it was standalone therapy?
Along with olopatadine or Patade or Bitoact, the Dipotaxin. So they work with that. But alone, I don't think they work. Mild idiopathic dry eye, they work. So similarly, VKC in control stage, they may work.
So Pragnya
I
or
have one question for
Yeah.
Prajakta, and that GPC. Here we get a lot of patient waiting for TRAB, for uncontrolled steroid-induced glaucoma, and they strictly request us not to start steroid. The patients are GPC with epitheliopathy, and in those cases, would you prefer a surgical excision? And if you go for surgical excision, do you give steroid post-op, or without steroid also somebody can manage GPC after this excision with AMG or whatever procedure that you combine?
The latest article which I could find on GPC was in 2020, and it has been mentioned that GPC also has an immunological component. So it is not only the mechanical friction which is taking place, it also has an immunological component. So to address that immunological component, we have to give some anti-inflammatory medications as well.
So, what is the opinion of other experts? How do you manage such cases? Because my cornea is combined with a glaucoma unit. So, we get every clinic, we get 2, 3 such patients with advanced glaucomatous damage due to steroid-induced glaucoma. And even though don't let us start FML or loteprednol, they say strictly no steroid. So, how
So
to manage such
in
cases?
oral medication.
in some patients, yeah, we give oral steroids and they work fantastic. And I think they bring down the size of the papillae as well. And we also, sometimes these patients are also too reactive to topical AGM. So you can, if they're adults mostly or adolescents, sometimes we give them oral astazolamide as well, bring everything under control. And oftentimes the pressures get controlled with just medical therapy. And very rarely do we have to resort to other therapies like surgical intervention.
Yeah, one of the alternatives, Dr. Praful, would be to give oral cyclosporin, because that is tissue remodeling is mainly the reason why your giant papillae are there. And actually, if you see, the cyclosporin acts on the T cell, which in general controls the anatomical changes that take place in VKC. So, with the use of oral cyclosporin, we have seen a lot of these giant papillae regressing. And even I think once the excision, like in the two cases that I showed, there was a the first case we gave a very short course of oral steroids, but I have not I mean, I don't think once you have treated and covered the raw area with CAG or a mucous membrane graft, then you need to give oral steroids. I think they'll do well with just the
Yes.
lubricants and the mast cell stabilizers.
And this is what I was asking you. Okay, do we need to give steroid after the excision and covering it with AMG or CAG? So I think you are right. Even we can manage without steroid.
Shweta, what is
Thank
your
you.
opinion for the exact question that Praful asked? So post
Yeah,
exit.
so I agree with most of the comments that have been shared. What we need to understand is always the giant papillae need not be treated. Sometimes, if they are flat topped and they're just there, they do not have to be treated. So, only if they are very active and you see that the center core is taking up a stain, do we need to treat those giant papillae. And if we need to treat them, a lot of times, a short course of topical steroids, I do understand that the glaucoma doctors are worried about steroid response and the pressures being high. But a lot of our patients where we have been seeing here and are going to be undergoing TRAB or something, we do give them a short course of topical steroids, and that's absolutely fine because they have oral acetazolamide and things which they can control with. And as far as Supriya said, yes, if you're operating it and surgically excising it, with AMT, you might have to still give them some course of topical steroids with MMG as well. So I think a short course of topical steroids, which you're giving for 2, 3 weeks, which is monitored by glaucoma doctors, should not be a problem. A long term, yes, is a concern.
Yes, and also there was one more point, like the giant papillae, which was traditionally because of the contact lenses. So it was because of the contact lenses which were used for a very long time. Like the daily disposable lenses were better. So there was a component where they have mentioned that other than the contact lens which causes the friction on the upper tarsal conjunctiva, it is also the debris which gets deposited on the contact lenses which causes immunological reaction.
So we've had a very interesting webinar. At least it was interesting to all of us, I'm sure. And we had absolutely outstanding presentations by all the speakers. brilliant presentation. We should somehow, maybe we should put together some kind of chronicles, Praful, for ARC, and have a compilation of such interesting webinars and circulate it through the ARC.
And if you remember, I think you were not that in that meeting. So what I had suggested, even Bhavan sir has agreed that we can come out with not preferred practice pattern, but standard practice pattern for
Right.
India specific diseases. And I think this webinar is just one such topic that is very important. We can come out with that, all the speakers, and we can contribute and how to manage such cases as practice pattern for Indian ophthalmologist.
Yeah.
Because our disease profile is completely different than Western kids. So I think we should do something like that.
I think we all agree on that. Any last comments from our chairs? Don't buy gold and
I
don't.
think we had a very interesting session. We had a quite comprehensive, very interesting session, Sumsila.
So I think all of you in this meeting made it extremely interesting. Once again, I express my gratitude to the platform of ARC for us to have this webinar, and deep gratitude to our chairs, to all the speakers who willingly accepted and who just had marvelous presentations. And I apologize for my rude interruption on time and things like that. I'm also thankful to my co-members, Kasturi and Prafulla, for being with me, as well as Prashant Bavankuli, who's given us this opportunity as the chairman of ARC. So wishing you a very good night and a great weekend ahead, and hope to see you soon in some other webinar.
Thank you, Dr. Shumas.
Thank you, Dr. Sumsila.
Thanks to
All the best.
So sorry.
Thank you.
Yeah, I couldn't participate very actively because I was also working with some meeting in the
Yeah.
ministry. Thank you so much.
Thank you.
Very good learnings for all of us.
We can stop recording in case you all are still recording. Thank you, everyone. Good night.
Thank you so much.
Thank you,
Good night.
everyone. Thank
Bye.
you. Thank you.
Thanks,
Thank
Shiva.
you.
Thank you. Thank you, Dr. Sumsila.
Bye.
Thank you. Thank you, ma'am.
Bye, boss. HOS boss.
Bye,
Bye.
Dr.
Thank you.
Bye.
Yes.
It was fantastic.